Today we are going to talk about fibroids. Joining me today is Dr. Jimmy Odinjinmi, who is a consultant gynecologist with a very keen interest in fibroids. He has published extensively about fibroids and he's very keen on teaching and training. He has had roles in the BSGE, which is the British Society for Gynaecological Endoscopy, and is very active in the society. And I knew he was the man for this interview when he said to me, I want to put the F in BSGE, referring to fibroids. Jimmy, welcome. Thank you so much for joining me today.
Thank you very much for the invite, Gail. Pleasure to be here.
So, Jimmy, as you're aware, this podcast is to educate patients. So we try to avoid medical terminology as far as possible, so it remains as accessible to everyone as it possibly can be. Is that okay with you?
That's great.
Okay, so let's start with the very basics. What exactly are fibroids?
Fibroids are benign growths. Some call them tumors, but I prefer just to call them growths because the majority of them are benign.
Yeah.
And they are growths that develop from the muscle of the uterus. They're relatively common, and in fact, 70 to 80% of women during their lifespan will expect to have a fibroid. The most important thing is that the majority of them aren't symptomatic, and that there is treatment for most people as long as they present early.
Okay, and are there different types of fibroids?
There are various types of fibroids, and like you say, there are two languages for fibroids, and a lot of the types of fibroids depend on their location. And the reason why this is important is because the location and size of fibroids often affects the sort of interventions that are necessary. And how we describe fibroids are in relation to the muscle of the womb.
Mm-hmm.
We describe the fibroids in terms of whether they're in the muscle, whether they're in the cavity of the uterus, or whether
Yeah,
they're in the outside of the uterus. And like I said previously, I brought a little prop to
yeah.
demonstrate what I mean.
Oh,
So
that's useful.
this is the cavity of the womb in the middle.
Mm-hmm.
This is what represents the muscle, and this will represent what's outside in the abdomen. So the fibroids within the cavity of the womb we refer to as submucous fibroids. Those within the muscle of the womb we refer to as intramural fibroids. The fibroids that are on the outside are referred to as subserous fibroids. And on occasion, you find that some of these fibroids are out on stalks, and they're called pedunculated fibroids. Now, that is the general language that we use, but it's also important to emphasize for people who are looking after women with fibroids, as you and I know, it's
Yeah.
important that we all speak the same language for the description. It's okay to describe them as I've just described in terms of discussions with our patients, but as
Yeah.
medical practitioners, we have to be a little bit more precise. And
Yeah.
there's a FIGO classification that has come in that doctors will discuss amongst themselves so they know exactly where the fibroids were in relation to the symptoms. And that helps to guide towards treatment.
Okay, so just to summarize what you've said, um, the there are three main types of fibroids in terms of location. Some can be in the cavity of the womb, and the cavity of the womb is the inside of the womb, for example, where babies grow, correct?
That's right.
Some can be in the wall of the womb, and that's in the muscle wall of the womb. And some can be kind of on the outside, like piggybacking on the outside of the
That's
womb.
right.
That's how I kind of describe it. And you say that depending on where these fibroids are and the size of the fibroids, it determines what treatments are available. Does the position of the fibroid also affect what symptoms a woman can have?
That's right as well. One would ascribe, in the most part, so if we're talking about symptoms related to fibroids, the commonest
Yeah,
symptom is heavy menstrual bleeding.
yeah,
There are other symptoms that we can come into later on. But we all believe that the submucous fibroids, the fibroids within the cavity, are the main culprits for causing heavy menstrual bleeding. But then, having said that, fibroids that are in the muscle of the womb, if they increase the sort of they increase the diameter of the uterus, thus increasing the amount of lining that's available, then that can also lead to heavy menstrual bleeding. So to summarize that again, the submucous ones usually always will, and the ones within the muscle, if they impinge on the cavity, will do that as well.
Okay. And that little model that you held up, which is really useful, just to be clear, women can have fibroids in all of those places, not just in one as well?
That is very true. I think for the majority of people who have fibroids, they don't just have one. A lot of
Yeah.
people have many.
Okay, perfect. And you say that fibroids are notorious for causing, you're right, heavy periods. Obviously, you're right. Heavy periods, that's the most common symptoms that women come along with. What other symptoms might a woman have that makes her think, well, maybe I might have fibroids? What are the other symptoms that women complain of?
Like we said, I think the most important symptom is heavy menstrual bleeding.
Hmm.
And the important thing to recognize about heavy menstrual bleeding is that heavy menstrual bleeding then leads on to anemia. Anemia then leads on to fatigue, and then you can't function, and then you've got loss of productivity. So we'll park that to one side. Sometimes you can also have irregular bleeding. You can have symptoms related to bulk symptoms, and you can have symptoms related to fertility. For the bulk symptoms, you have things like constipation if you get it pressing on your bowel. And you can have frequency of going to the loo, for instance, frequency of micturition, particularly if the bladder, if the fibroid is pressing on the bladder. So to compartmentalize, you've got the heavy menstrual bleeding symptoms, you've got
Yeah,
painful periods, you can have problems with intercourse if you've got either bulk symptoms or you've got fibroids sitting in places that interfere with intercourse. You then have the bulk symptoms in relation to micturition, passing water. You've got the
yeah,
symptoms relating to constipation.
yeah.
And then you've got the other symptoms that result from those symptoms, just like heavy menstrual bleeding, you get fatigue, anemia, and those sort of things. And then you just have a miserable life because of all the combination.
Sounds like it. Yeah,
And it's
absolutely.
important to recognize also that most people will have more than just the one symptom, just like they have more than one fiber, they have more than one symptom. And those symptoms need to be addressed individually as opposed to just as a collective sometimes.
And the other thing that's variable in fibroids in women is where they are, how many there are, but also the size of fibroids, which can vary tremendously. Yes.
That's right. So fibroids can vary in size from pea-sized to
Hmm.
very massive fibroids that can actually engulf the whole of the abdomen.
Yeah.
Um, and the symptoms that they cause are not necessarily always related to their size, because you can have very small fibroids that are submucous in the cavity of the womb that can
Yeah.
cause severe uh, bleeding. And sometimes the fibroids in the cavity of the womb can also cause severe pain. You can have fibroids sitting on the outside of the uterus in where we call the pouch of Douglas that can actually then cause pain, can block off kidneys, and can do all sorts of damage.
Okay. And do we know why fibroids happen?
I think that's a very good question. We think we know why fibroids happen, but if we didn't know why fibroids happen, then we probably would have a cure for it. I think there are very many theories as to why fibroids happen. People think, or we think that the majority of fibroids are hormone related. And that's one of the reasons why the longer you go on with your menstrual periods, the earlier you start and the later you finish, you're more likely to have them. And people seem to think that estrogen is the main driver and progesterone helps it along its way. Then you've got other things like growth factors, you've got all sorts of things that can actually influence what we now know to be the extracellular matrix. So you've got a lot of sticky stuff in the tissue of the fibroids that cause those fibroids to grow. So that's the hormonal bit. You've got the extracellular matrix bit. You've also got things down to with genetics. So
Yeah.
there are some genes that predispose women to fibroids, but even though we have identified those genes cannot at the present moment be turned off to prevent the fibroids from happening. You've got epigenetic factors that people think that the epigenetics is one of the reasons why women go on to develop fibroids. You've also got things like diet, and things that you can do about diet and things that you can take supplements and things. But even though those are associations, there is no direct correlation between the diet and the absence or presence of fibroids.
And is there anything concrete? Because patients ask me this all the time. Is there anything that I can do to prevent getting fibroids or getting more fibroids? Is there any? again, if we knew that, but anyhow, is there
Amen.
anything women can
I
do?
think I think, as we'll come to later on, I'm sure, in the discussion about
Yeah,
early
yeah.
detection, so that you can do something about it. So, as a general rule, because we don't know what causes fibroids, it's very difficult to say do this or do that, and that will happen.
Hmm.
But
Hmm.
there is emerging data to suggest that there are certain women who are predisposed to developing fibroids. And there are certain things that you can take that will stop the chronic inflammation, which is thought to be one of the reasons why women develop fibroids. So things like vitamin D, for instance, and things like green tea extract. In fact, for most of my patients these days, if they had their operations, I would say to them, even though the data suggests that there is a decrease in recurrence risk for fibroids for
Hmm.
people who take vitamin D and green tea extract, it is a good idea to take them because they won't do you any harm.
No harm.
And again, if the data is true, then it's a win-win situation.
Very true. And it's an easy thing to do, isn't
Mm.
it?
The other thing to say is stress related, because people say, they've got diet sheets, and in fact I read a diet sheet, but the diet sheet that people actually produce is the same as diets for most things. If you
Right.
eat healthily and don't overindulge in most things, then you engage in exercise, stress-free living, and that sort of thing, that applies to the stress and the chronic inflammation that women who have fibroids seem to have.
Okay. And before we go any more into things like treatment and things, um, if you say that a majority of women will have at least one fibroid, is it possible for women to have fibroids and have no symptoms? And if they have no symptoms, is it necessary to do anything with the fibroids?
Good question. So the issue here is, as long the introduction for most texts is that fibroids are common. Most women will have fibroids, but the majority of women who have fibroids will not be symptomatic.
Yeah.
So that is the statements that are parked. The truth is that the majority of people will not need treatment for their fibroids. However, it is sometimes difficult to determine who will and who won't. And at the present moment, the issue usually is we say to women, well, the fibroids are not symptomatic at the moment. Go with God and we'll see you whenever you begin to have symptoms. And that
Hmm.
may well be that, yes, the watchful waiting approach is great, but it may well not be good for each individual. And one of the reasons being, it's impossible to say in whom the fibroids will grow, and it's impossible to say in whom they don't. And in fact, there have been studies that have shown that in the same individual, fibroids grow at different rates, and in different individuals, they grow at different rates. So, as much as for the majority of people, fibroids are not symptomatic, my personal view is that we put things in place to be able to help those people who present later in life, once they have planned everything else, but come with these symptoms and loads of big fibroids. And
Yeah.
that is what um, I see every day. And it's sort of one of the things that we should be able to get rid of.
Okay. And for argument's sake, if just tell us about the natural history of fibroids. So they're hormone dependent. So, little girls don't have fibroids. Eventually they develop over a woman's lifetime. And talk me through what happens if we do nothing with the fibroids. Yes, they may grow and they may grow at a different rate, but what happens kind of eventually if we do nothing?
So eventually, say for instance, the earlier you start having periods, the more likely it is that you'll have a long reproductive life. So fibroids usually appear during the reproductive life.
Yeah.
Before adolescence, you rarely find them. You would find them in a few individuals, but as a general rule. But if you're
Yeah.
lucky to get through life and towards the end of life you haven't developed fibroids, the menopause is actually a cure for it. And that is what has led to the development of fibroid-specific drugs that actually help for women who have fibroids to trick the body into thinking, well, it's menopause time and therefore the fibroids stop growing. So to summarize that, adolescents very rarely have fibroids. Fibroids grow in the commonest group of between 40 and 60 in the most part.
Mm-hmm.
But usually after the age, once you've gone into the change and the menopause ensues, then the fibroids should stop causing symptoms. But I think one of the myths that we also need to get rid of is that the fibroids will shrink. They don't shrink in everybody. So they may well still cause pressure symptoms, but they shouldn't grow.
Okay, great. That's the point I wanted to get out, that eventually the symptoms should abate if
That's right.
after menopause. So well put. Thank you very much. And so a woman has the symptoms of heavy periods, for example. Another question I wanted to ask is, what about fertility? Do fibroids affect fertility? Because that's a
Again,
big,
that is a big question and a
yeah,
very pertinent question. I
yeah,
think the starting point, the conversations I often have with my patients are that the majority of people who have fibroids will get pregnant, and the people who do get pregnant will get pregnant and have no problems. However, there is a large proportion of people who will find it difficult to get pregnant,
yeah,
particularly in the society today that we live. So most people postpone childbearing for whatever reason, but we can only deal with the problems we have in our generation, and that is one of our generational problems. So the issue still is that from the fertility point of view, if you went to a fertility clinic, a lot of people who are sat in the fertility clinic will have fibroids.
yeah,
Now, the argument that usually ensues is that how do you separate people who have fibroids and infertility from patients who would have had infertility with a fibroid if they didn't have fibroids? And that has
yeah,
always been the bone of contention. And my guess is that there are more people who have fertility related issues with fibroids than we think there are at the present moment. The difficulty usually is defining who does and who doesn't. And that again brings us to the question of the location of the fibroids and what current evidence tells us. I mean, a lot of the information that we say to patients, the 2 to 3% infertility, comes from a paper, for instance, that was written in the 1980s. And a lot of knowledge has been gained since then. So,
yeah,
therefore, you would think to yourself, of the women who do have fibroids, a fair proportion will have fertility issues. And the ones that do have the main fertility issues are the ones with the submucous fibroids, the ones that are in the cavity. That we know for sure. And all
yeah,
of the studies point that, if you do something about those particular fibroids, then fertility should improve. There is emergent evidence to say that the fibroids in the muscle of the womb can also cause issues with fertility. And the closer they are to the cavity, the more likely they are to cause fertility issues by a number of mechanisms, and not only just by distortion of the cavity. Then people say, well, what about the subserous ones? The
yeah.
majority of the subserous ones don't, but I'm very sure that you've come across those ladies where you do a laparoscopy, you've got the tubes, and then you've got fibroids sitting on each of the tubes. So you've got that mechanical issue
Okay,
about fertility.
yeah, okay. So they can certainly impact so they can impact really every avenue of a woman's life, you
That
can
is
say.
right.
Okay. And so, yes, as I was saying, maybe a woman is listening to this interview, listening to you, and thinks, that sounds familiar. I've got those symptoms. I think I might have fibroids. Um, can you talk her through how fibroids are diagnosed, what she can expect if she goes to her doctor to investigate this?
I think the most important thing for diagnosis of fibroids, for anybody who's listening to the conversation, if you do have those symptoms, then those are the
Mhm.
sort of symptoms that you need to relate to your doctor. And most doctors will be able to tell from the symptoms that you have described that there is something wrong. The issue usually is, so, say for instance, you've got heavy menstrual bleeding or you've got the pressure symptoms. There are lots of women who don't have fibroids who have those symptoms. And sometimes if you mix them both together, then the people who have fibroids don't get the best care they should. So you go to your doctor and you say, this is the situation. So the doctor listens, takes your history, and again, sometimes takes a family history because fibroids run in families because of the genetic disposition.
Yeah.
Takes the history, and then the next important thing is an examination. Patients examined, sometimes that involves an internal examination. And once the examination's done, then the next point of call is usually an ultrasound scan. So usually an ultrasound scan at the minimum. And what I normally say to my colleagues and my primary care colleagues, it's always useful to do a full blood count at the same time so that you've actually got some sort of baseline as to what to base things on. So to summarize, you have a history, examination, and in the minimum, an ultrasound scan. And the ultrasound scan that you have will depend on the number, size, and site of fibroids. For small fibroids, it might well be a transvaginal scan. For larger fibroids, you might need an abdominal scan because sometimes it's difficult to see those larger fibroids with a transvaginal scan.
Okay, so our patient has been diagnosed as having a fibroid or fibroids. What treatment options can she expect to be discussed with her? So what are the options available for treatment of fibroids?
So I think the beginning of the discussion for anybody who has fibroids, because there are various ways in which fibroids are diagnosed. Sometimes they're diagnosed as just part of some other investigation. Sometimes they're asymptomatic. But I think the most important, the beginning of a conversation in modern times is just because you have fibroids doesn't necessarily mean you've got to have treatment. And that's the key. And if you do decide that you have treatment, the treatment should take into consideration what your current symptoms are, as well as the benefits and the downsides of each intervention you choose. And a lot of that will be driven by the site, size, and number of fibroids, desires for fertility, as well as what is actually happening in that person's life circumstance at that particular point in time. The other things that come into play are things like comorbidities, because there are things like diabetes, hypertension, and just the general background situation of the individual. So once that is ascertained, you've had your investigations, we know what the site and size of the fibroids are, then the discussion starts. And the discussion usually starts, you go from the least invasive to the most invasive. So for most women, say for instance, you have a diagnosis of fibroids, small fibroids, you're in your 20s, you haven't thought about pregnancy or anything like that, and your main concern is your current symptoms. If the fibroids are small, it may be that you will start on the oral contraceptive pill or some sort of hormonal medication. For some people in whom you've got only small fibroids and heavy menstrual bleeding is the main symptom, then you might be able to take some non-hormonal preparations. And the commonest preparation is usually what we call the non-steroidal anti-inflammatory agents. And the way they work is that they deal with some of the hormones that cause heavy periods. And they can reduce the flow of the periods by about 20-30%. They can be combined with things like tranexamic acid, which in medical jargon is antifibrinolytic. And you put them together, sometimes they act synergistically and can reduce menstrual flow by about 30%. The plus side is that they control the symptoms. The downside is that they don't do anything about the size of the fibroids. So that's non-hormonal management. You then come to hormonal management, and the mainstay usually is for small fibroids. For someone who wants fertility in the future but doesn't want anything at the minute, you can use the oral contraceptive. Again, it will deal with the symptoms, but it won't do anything for the size of the fibroids. And if you read some modern texts, it would actually say there is a risk if you take some progesterone things that you might grow your fibroids. You then move from there to the progesterone-only preparations, things like noethistérone and Provera. Again, they don't do very much for the size of the fibroids, but can do a lot for the symptoms. You then move on to, before I move on to other things, I think the important thing to emphasize here is that limitations of medical management is usually by the side effects and the effects that they have on the fibroids. So there are some women who will take them easily without side effects, but if you develop side effects, then you'd have to go on to something else. So that then brings us to the intrauterine contraceptive devices that release levonorgestrel. So there are things like Mirena or Levocert, and they are useful in reducing both pain and flow of periods by up to 30% or so. So if you've got small fibroids, then it's a good idea to try things like the Mirena, particularly if you need contraception as well. The downside of the Mirena, for instance, is the fact that for people who have sizable fibroids, expulsion rates can be as high as 20% or so. So it's always mindful to remember that if you've got a Mirena inserted, then if you have heavy periods, that it can come out without you knowing. So that goes for the first-line medications. Then you've got some newer medications that have just come online, there was ulipristal acetate, which I won't talk about very much because that's
No.
sort of on the back burner at the minute.
Yeah. Yeah.
But there are the newer medications, and they are GnRH antagonists. And the beauty of these molecules, as I say, they've been developed primarily for fibroid care, as opposed to the older preparations that weren't. And they sort of switch off the pituitary gland, which is the gland that controls most of the hormones in the body. And that in turn decreases the sex hormones, as they're called, LH and FSH. And that sort of down-regulates the ovaries, fooling the body into thinking it's gone into the change.
Yeah.
The beauty of this is that, for the most part, it controls symptoms. It also stops the fibroid from growing. And there are some preparations that actually reduce the size of the fibroids. The downsides of these medications is the fact that when you do take them, what then tends to happen is you then get the side effects of being menopausal, and therefore you need to have some add-back therapy to stop things like hot flushes, night sweats, and things like thinning of the bones known as osteoporosis. And that is one of the reasons why you can't take these drugs forever. They need to be monitored closely, and sometimes they are sort of a stopgap between treating your symptoms, making sure the fibroids don't grow so that you can prepare for your fertility life when you're ready. So that is the spectrum of medications that are available. And again, I think the most important thing about management of fibroids is the individualization of care that women should actually have access to.
Yeah.
So you've got those medications, and then you've got the minimally invasive procedures, and then you've got things like uterine artery embolization, for instance, which is very common. It goes by many names. And the plus side of uterine artery embolization is the fact that you avoid major surgery. The downside of a uterine artery embolization is, even though women who have had it can get pregnant in the future, it would not be the first point of call for women who want to be pregnant in the future because of potential pregnancy-related issues that can sometimes happen. So for women who have completed their families, who have got fibroids, depending on where the fibroids are, because there are certain contraindications. If you've got a large intracavity fibroid, for instance, it's probably not the best thing to do. But it's also important to realize that that is available if you've completed your family. You've got new things that have come online, and I'm sure you can say more about these radiofrequency ablative techniques than I can. And they are also options for women who have completed their families, though there have been women, again, who have had these radiofrequency ablation device techniques and have gone on to be pregnant without any problems.
Any issues? Yeah. Yeah. So I'm going to do. So my next interview is actually about Sonata.
I should
So
interview you for that.
yeah. So if anyone is interested in radiofrequency ablation or Sonata treatment for fibroids, stay tuned for my next episode when I'll be interviewing someone about Sonata. But do go on. Do go on.
Okay, so we then get on to surgery. So
Yeah.
what we have said so far is that a person has been diagnosed with fibroids. We have taken their individual circumstance into consideration, and there is an array of things to choose from. The beginning of it is that just because you've got fibroids doesn't mean that you have to have treatment.
Yeah.
And the other statement that I would make before I go on to the surgical techniques is there is no such thing as a prophylactic operation. You don't need to have an operation for something that may never happen. The question we then ask ourselves, are we having an operation for the symptoms that we have at the minute, or are we having an operation for symptoms that we may develop in the future? It's a very difficult one in view of the fact that fibroids of a certain size are amenable to minimal access techniques, whereas when the fibroids go to a larger size, then you have a larger operation with the consequent complications that can happen. So I then park that statement, and then we talk about surgical interventions.
Mm-hmm.
For women who have fibroids in the cavity of the womb that are less than 5 centimeters, then it may be that they would opt to have, if that's a solitary fibroid, for instance, they may opt to have what they call a transcervical fibroid resection. And again, the eligibility for that will be discussed with the carer. But that is probably the commonest intervention that women have for the management of their fibroids. Then we go on to things like Sonata as well, again, there are certain criteria that I won't go into for the sake of time. And then that brings us to the commonest procedure that women who want to be pregnant, who have symptomatic fibroids today have, and that's a myomectomy. Again, the first point of call that I say to all the patients that I see is that just because it's available doesn't mean you have to have it.
Yeah.
And there are certain ways to do operations for fibroids. And one of the things we've got to be able to do is to balance up the immediate complications of the procedure versus the potential complications that the procedure can lead to. The procedure in itself will stop you from getting pregnant. So those are the things that you've got to consider when you decide to have an intervention. And there are certain occasions where you can combine some of these interventions just to suit your individual circumstance. So there's a myomectomy, and the ultimate treatment for fibroids is a H word, the hysterectomy word. But again, one of the things we've got to take into consideration that we now know that people who have hysterectomies at a young age, even if they have their ovaries left behind, will develop some long-term complications, particularly because they're not routinely monitored for the menopause. So I hope I've covered most of the treatments, and then we can talk about the treatments and the complications as we go on.
Yeah. So what you're saying with that last statement, just to clarify, is that women who have hysterectomies at a young age, it's a big undertaking because it's major surgery, but also there's evidence that they may have an earlier menopause. Is that what you're saying?
That's right. But even if the ovaries are left behind, they have earlier menopause.
Yes, I mean, even if the ovaries are left behind. Yeah, absolutely.
Yeah. And the issue is that over a number of years, there have been certain people who have actually studied the longer term effects for people who have had their ovaries left behind. Because one of the difficulties that women sometimes have is that you don't have periods. You have the occasional hot flush you don't pay very much attention to. And then you get into your 60s and find you've got osteoporosis and all those sorts of things. Remembering that you had a hysterectomy a number of years ago that has led on to those things. For people who have their uteruses left behind, often when their periods stop, they seek HRT in the modern age, which people who have had hysterectomies don't tend to do as early as others do.
Yeah. Really good point. Okay. So, that's a great, you really tackled all those options because there are so many, and with each passing, I don't know, 5 years when you've been doing this as long as we have, new options keep coming online. So thank you for covering them all. Shall we talk a little bit more in detail about surgical options? So, start with the hysteroscopic myomectomy or fibroid resection. Should we start with that and work our way up?
So the commonest treatment or the commonest intervention, minimally invasive intervention in most countries is a hysteroscopic myomectomy. And a hysteroscopic myomectomy can be with an anesthetic or without an anesthetic, depending on how big the fibroids are and depending on what discussions we have with our patients.
Yeah.
The issues around transcervical resections, as they're commonly called, is the fact that if you have a fibroid that needs to be resected, you want the fibroid to be resected in the most part in one go. The issues usually are is the bigger the fibroid gets and the more it is into the muscle of the womb, the more unlikely it is that you're going to be able to resect it in one go. The issues that then stem from that are the issues of needing to have repeat operations and needing to then developing adhesions within the uterus that can actually lead to fertility issues. Yeah. So sometimes what tends to happen, if you suffer from heavy menstrual bleeding, what doctors can sometimes do is prescribe the GnRH analogs, shrink the fibroid a little bit, and then offer the transcervical resection. So the best type of operation is your first operation, and the best type of operation is that they're all done at the same time. One of the exceptions to that, one of the things that actually increases sometimes the complication rates, is if you've got fibroids on both walls of the uterus and then you resect them, and that sort of increases the adhesion risk. Yeah. So that hopefully covers what you need to know about a transcervical resection of a fibroid. So the next discussion we have, you were going to say something, girl?
No, go on. Yeah, no,
The
I was
next
just
discussion we
let's
have
move on.
is about the commonest operation, as they say, for women who want to either retain their womb or retain their fertility. And that brings us to a myomectomy. And the type of myomectomy that women have will depend on the number, site, and size of fibroids. It's important to say here that the jury has always been out as to how many fibroids there should be, or how big the fibroids should be, and what the method of treating those fibroids should be. And I'll touch on that in a little while. But the important thing I say to all women is that just because they're there doesn't mean you have to take them out.
Mm-hmm.
So for fibroids, say for instance, you've got moderate sized fibroids, the important thing is to have that discussion with the doctor to say, these are the fibroids and these are my aspirations and this is what I expect to get out of the procedure. The doctor then says to you, well, yes, that is it, and this is what I have to offer. But I say to women at this point, the important thing is to seek a second opinion and to educate yourself as much as you possibly can before you commit to any one procedure. So, from the myomectomy point of view, traditionally they were done open, but now it is possible to either do them with the laparoscope or robotically. And again, it depends on the number, site, and size. And sometimes it also depends on the experience of the surgeon that you see. The conversations that need to be had when you opt to have a myomectomy are not necessarily the intraoperative complications, but the things that you expect as a result. And the one thing I talk about in the most part is the development of adhesions. So adhesions are scar tissue that develops after any operation. And the analogy that I often give is if you cut yourself on your hand, the tissue that develops is usually different. And if you were to cut your two fingers and stick them together long enough, they will attach themselves to each other. And that's what happens after an operation. We know that 90% of people who have open operations will have adhesions as a result of a myomectomy. And we say to women that that is actually halved if you have a minimal access procedure, both in terms of the intensity and the number of adhesions that you have. And sometimes it also depends on the location of the fibroids. So that is the first thing. And the important thing to note is that those adhesions in themselves can be either a cause of pain in the future and can also be a reason for fertility issues in the future. So that needs to be taken into account. What we also say to women is that the fibroid operation can be a bloody operation sometimes. And the important thing to note is to try to make sure that you optimize yourself as best you can. So you take your iron tablets, make sure that you exercise before your operation, eat healthily, and those sorts of things. Because there is a transfusion risk. And the transfusion risk is anywhere between 1 in 20 to 1 in 50. And the fitter you are when you go for a fibroid operation, the more likely it is that you will benefit from it and you will recover quicker. The next thing we talk about is a hysterectomy risk. And even though,
Just pause you there. Oh,
yeah,
sorry. Just to pause you to say that I just don't want this point to be lost in your brilliant discourse you're giving me there. You mentioned about hysteroscopic myomectomies, and all operations. If you can do things through one operation, the first operation is the best operation, and the fewer operations, the better. And I think that is an important part of counseling with myomectomy, actually, because you know you've got to gauge. So sometimes we do myomectomies, and we remove 47 fibroids or 52 fibroids or whatever the case may be. So some women are really good at making fibroids. So there's a decision as to when to do this myomectomy, because you don't want to remove 16 and then 2 years later she's grown another 10, have another operation and another operation. So I just didn't want that to
that's a part.
yeah,
And that
sorry.
again is an important point. And it may well be that we'll talk about that towards the tail end of the discussion, because, like
Yeah,
you rightfully say, you have to choose when to have your operation.
choose when.
And I was going to talk about that whenever we talk about recurrence and reintervention.
Right. Okay. Perfect. Thank you. We'll leave it till then.
So,
Then you were talking about hysterectomy
so
risk.
we're talking about the hysterectomy risk. The
Yeah.
hysterectomy risk is not actually common. The figure that I give is sort of about 1 in 250. So I would say to people that if I were to do one a week, it would take 5 years for that to happen to one person. But then I'm only as good as my last operation. So I don't say it's lightly.
Like,
It's very uncommon, and it's important to ask those questions to your surgeon. How many have you done? How many times has that happened? And that sort of thing. So that's the hysterectomy risk. So
and
like
why
Gail
would you
was saying,
do a hysterectomy?
pardon?
Why would you need to resort to a
The
hysterectomy?
only time that one would resort to a hysterectomy is that if all other methods of trying to save, um, to stop bleeding haven't worked. And there are very many other things that you can do before you resort to having a hysterectomy. Um, so we were then going to talk about the recurrence risk. And each muscle of the uterus has a potential to become a fibroid. And that's usually the starting point of that particular conversation. A myomectomy per se, just like Gail was saying, is not treatment for fibroids. It's treatment of symptoms. And usually what I say to women is that I'm yet to meet someone in whom the fibroids have not regrown, either my patients or in others. No one knows when it will happen, and nobody knows how many there will be. What happens between when you have your operation and when they do come back is what is important. And in that case, do you need to have your operation now for your symptoms, or would you prefer to defer your operation if your symptoms are manageable to such a time where fertility is within slingshot? Or
Yeah.
say, for instance, if you haven't got a partner, you're thinking of getting married in 5 years' time, and you've got that solitary fibroid, it may be that you'll decide to have some medical management, particularly with these new molecules, and then come back towards that time and then have your operation then. So the recurrence risk for most things, and you have to compare the recurrence risk between things like the uterine artery embolizations, the sonatas, and the myomectomies. The recurrence risk that is usually quoted is anywhere between 5 and 40%. And that really depends on the number of fibroids and sometimes the size of the fibroids and when you have your operation. So if you have your operation at a young age, it is more than likely that the fibroids will come back over time. If you have many fibroids removed, it is very likely that the fibroids will return over time. And it may well be for such women or for such people, what we would then decide to do is to put them either on the vitamin D and GnRH analog, or decide to put them on the GnRH antagonists to see whether that will stop those fibroids from regenerating. So the regeneration is a problem. The other thing we talk about when we talk about myomectomies is the reintervention risk, because recurrence risk is very different from a reintervention risk. A recurrence risk is they will come back, but just because they're back doesn't mean they have to have an intervention. So as a general rule, what I say to women is that 5 to 10% of people who have an intervention for their fibroids by myomectomy within 5 to 10 years will require some reintervention for their fibroids. The last thing we talk about is talking about symptoms. For the majority of people who have fibroids, the myomectomies are very effective. For 80-90% of people, heavy menstrual bleeding will get better. The pressure symptoms get better. For about 20% of people who have tried to be pregnant who haven't, it increases the chances of pregnancy. But there are a certain number of people who may not improve. And those sort of people might well need to have some adjuvant therapy to help them along. One of the other things I talk about when we talk about myomectomy is the issue about morcellation, because if you're going to have a keyhole procedure, you will need to have morcellation.
Can you explain what morcellation means?
So, a morcellation is what happens after a keyhole operation or after a laparoscopic myomectomy. And a laparoscopic myomectomy is usually carried out through a 5 millimeter incision at the belly button. You've got two 5 millimeter incisions on the side and maybe a 12 millimeter incision above the hairline. So if you've got a 10 centimeter fibroid, there is no way that is coming out through those little holes. So under those circumstances, what needs to happen is we put in an instrument, and that instrument helps to core the fibroid. So it comes out in little strips. One of the reasons why we're cautious about morcellation is that there was a particular case in, I think it was 2014 in the States, where there was an unfortunate thing about the spread of a cancer, and the woman succumbed to it. But the important thing to note is that the morcellation in itself was not the culprit, it was the fibroid in itself. And then people then ask me, what is the risk of cancer in a fibroid? That risk is actually quite small. Again, it depends on what race you are, and again, it depends on how old you are. The average person who has cancer in the fibroid is relatively old. The fibroids are relatively large. So for young women, it is very unlikely that the fibroids are cancerous. And one of the ways we get around that is to do MRIs before we do myomectomies. And the majority of MRIs, if they're normal, it's unlikely that there will be cancer. So that brings us on to how we then do the morcellation. In modern times, because of the NICE guidelines and the guidelines from the BSG and the RCOG, what we do is to put a bag into the pelvis, morcellate the fibroid in the bag in order to get it out and take the bag out.
Just grind it up.
Yes. There is no evidence to say it reduces the risk of cancer, but it reduces the spread of the fibroid within the abdominal cavity, which is most important. Once we've parked that discussion, we then go on to talk about the risk of rupture of the uterus after. So what happens during pregnancy, doctor? And what I say to women is the fact that the risk of rupture is actually quite low. It doesn't matter whether you've had an open operation or a laparoscopic operation, and usually it falls to less than 1%. The majority of people in whom it will rupture before the end of before labor starts. For the people in whom it ruptures during labor, as long as they're in a labor ward, most of the babies survive and all of the mothers survive. So it's not necessarily something that commonly happens, but when it does happen, there is usually remedy for it. So when I finished having that discussion, I then talk about the feasibility of doing it laparoscopically or open. Laparoscopic is always best, and if I can get away with a laparoscopic procedure, then that's what I would prefer over an open procedure. But it's usually limited by the number of fibroids, the size of the fibroids, and how the fibroids are related to the uterus.
Okay, and can you talk us through some risks of the surgery that you think might be important to mention that might influence a woman's decision as to, for example, should she go with, say, a woman with no reproductive ambitions, she's completed a family, she has a reasonably sized fibroid, because you can't embolize tiny fibroids, they have to be a certain size. And she's trying to decide between, for example, embolization or surgery, either myomectomy or hysterectomy.
So we've got those three modalities, rightfully so. Say, for instance, family is complete, and then we think about what the pros and cons are of every procedure. I think the starting point is you start from the least to the most invasive. And as Gail was saying, what we've got to be able to think about are the benefits we get from the procedure, the risk of recurrence, and the morbidity attached, or the sickness that is attached to the procedure that we choose. So a uterine artery embolization is usually available for women who have completed their families, who have got reasonably large fibroids, but the fibroids shouldn't be within the cavity of the womb as a general rule, and they shouldn't be pedunculated. That means out on stalks in the abdomen. So once we've decided that in the fibroids, and it depends on what you want to get out of it. One of the things about a myomectomy is you usually get immediate results. But if you've got an embolization, then it might well be a gradual thing. The beauty of an embolization is it can be done as a day case. Recovery is usually quicker. The things that sometimes happen is you feel a little bit sick afterwards. It can be painful. You can develop an infection. But by and large, within 2 to 4 weeks, you should be back to your normal self, and then just wait until the effects wear off. One of the things that we talk about as far as embolization goes is the risk of premature menopause, but that would happen in less than 1% of people, and usually in women who are over the age of 45. We also talk about vaginal discharge, which can actually start for a very long time. And sometimes, if you've got what we call these submucous fibroids, they can actually prolapse and come out, and that in itself requires a second operation. The issues, if you compare a laparoscopic or a myomectomy to a uterine artery embolization is the fact that the reintervention risk is greater with uterine artery embolization if you compare it to a myomectomy. So I think that sort of compares those
Yeah.
two. And then we go on to then talk about the issues around a myomectomy or a hysterectomy. And that conversation usually happens to women who have completed their families about the age of 40 or thereabouts. In the olden days, it was said, if you've completed your family, just whip it out and everything will be fine. But there are other things that influence what outcomes are in terms of just whip it out. There are complications that happen as a result of these operations that we choose. The immediate complications like bowel injury, injury to your bladder, and the organs that surround the uterus are one of the things that we should take into consideration. And then you compare a myomectomy with a hysterectomy. If you're having an operation where the collateral damage is about the same, but the issues around a hysterectomy and a myomectomy is the fact that the fibroids are removed and the uterus stays behind. With a hysterectomy, the uterus is taken out. If you were younger and there was a trade-off of pain and that sort of issue, then a hysterectomy might be not a good idea, because even if you do have a bit of pain, you've still got the womb and you can still have babies. But for the older person whose family is complete, they may well say to have a hysterectomy. The reason being is that they don't have the pain, they have a reduced risk of recurrence. But one of the things that they need to keep in mind is what we talked about earlier. If there are some women in whom, even if the ovaries are left behind, that there is still that small risk of chronic illness.
Okay. And just to be clear, an embolization, so of course we're two gynecologists speaking about things we do every single day. So just to be clear, an embolization is a radiologic procedure. It's not a gynae procedure.
That's right.
So it's not performed by a gynecologist like you or I. It's performed by a radiologist. And can you just briefly, in one line, explain what an embolization entails?
So, like Gail says, we refer you to a radiologist. In most cases, in modern fibroid care, there's an MDT to see what the suitability is. So once the suitability has been discussed, you can see the radiologist. And then what the radiologist then does is to make some little incisions either in the groin area, sometimes just a one incision, puts a little catheter in, and then the objective of the exercise is to block off the blood supply to the uterus. And in blocking off the blood supply to the uterus, the expectation is that the fibroids will decrease in size. And the figures that are usually banded about, depending on the size of the fibroid, is that you would get a 40 to 60% reduction in fibroid size. The procedures are usually done as day cases or overnight stay. They can be painful and you have some pain relief that is usually attached. And the discharge usually happens in the morning. So you're discharged the day after for the majority of patients, and that's usually what the expectation is. And like we said before, the issues about the embolization is that the effects are usually not immediate. You would have probably a 3-month follow-up and a 6-month follow-up. And it's only at 6 months that you would know what the state of play is going to look like. And by a year, for anyone who's expecting improvement, the improvement should have happened.
Yeah, but they're very effective procedures.
That's right.
Okay, so you're going to go on to talk about myomectomy and hysterectomy.
So the thing about a myomectomy, the advantage of a myomectomy is that you keep your womb.
Yeah.
And I think the beginning of the discussion is the fact that just because you've completed your family doesn't mean you may not want to keep your womb. So if you do want to keep your womb, then every effort should be made for that to happen. Once you've had a discussion about the pain and the risk of recurrence, and you actually look at if you have a myomectomy, say for instance, when you're 45, it's very unlikely that it will come back before the menopause. So it's an acceptable option. And usually, say for instance, if you've got a single fibroid about 10 centimeters, or you've got a number of smaller fibroid, medium-sized fibroid, it's a good idea. For women whom it's not a good idea is if you've got a belly full of fibroids, then that may well not be a good idea. Neither would the embolization be a good idea. For such women, unfortunately, a hysterectomy is probably a better option. But my main wish in life is that nobody comes to that. That it would be a matter of you've got an early diagnosis, things are managed before you get a belly full of fibroid.
Yeah, well said, well said. Okay, so wow, that's been a really enlightening discussion. And you've been very clear and very articulate, so you did not disappoint. Um, I have one last question for you. Jimmy, you've looked after hundreds of women in your career thus far with fibroids. Given the opportunity to speak to women who either suspect they may have fibroids or have been given a diagnosis of fibroids, is there anything you'd like to say to them today?
I think the most important thing is if you feel you have fibroids based on family history, based on your symptoms. And one of the things that we didn't cover, because it's not necessarily, because one of the myths around fibroids is it's a disease of ethnic minorities, which is not necessarily true. It's probably more prevalent per population, but there are more non ethnic minority people who have fibroids than Black people in terms of numbers. So that's one of the things that we need to take into perspective. But based on your history, based on your symptoms, the important thing to do is to seek help. One of the important things to also recognize is that we're not alone. One of the issues that sometimes impairs how fibroids are managed is that people are stigmatized, don't want to come forward, and therefore keep everything to themselves. But one of the things that women have to realize is that they're not alone in this battle, that there are very many other people that have these symptoms. And the more we get together to find solutions to those problems, the better it is off for everyone. So that's the first point. So come forward as soon as we can. The second point is to educate ourselves as to what the best treatments are and to investigate to make sure that the treatment that you're offered suits your present circumstance and also takes into consideration your future circumstance as you would want it. The third thing I would say is that not one thing fits all. So it's a matter of being able to switch from one treatment to another as the situation evolves. So hopefully that is the advice. So education is key. Seek a second opinion should you need one, and collaboration is most important. One of the things that happens to people with fibroids is, as a collective, because of the heavy menstrual bleeding and bulk symptoms, you're sort of grouped together with other individuals, and therefore the treatments that they deserve are not readily available.
Yeah, 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 yeah. Well, I couldn't agree with you more. The importance of education, which was the whole reason for the genesis of this podcast. And hopefully, women will have access to hear your wise words and benefit from your wealth of experience about fibroids. So I'd like to, in closing, Jimmy, thank you so much for joining me today.
Thank you
Thank
very
you.
much, Joe.
Thank you for supporting me in trying to educate women, and I know you're very keen on that. But most of all, thank you for your decades of hard work in gynecology and particularly helping women with uterine fibroids. Thank you so much.
Thank you very much for the invite. And yes, upwards and onwards. The more that we can do, the better.
Thank you.
Thank you very much.